Bonjour tout le monde, bon après-midi et bienvenue à ce webinaire sur l'orientation à la santé au point d'entrée et frontières dans un contexte d'épidémie de filovirus. Je m'appelle Lionel Nizigama, je travaille avec l'unité de préparation en cas de grippe pandémique dans le bureau régional Afrique et je serai votre modérateur pour cette session. Donc, comme vous le savez, les épidémies actuelles de Marbourg et de virus Ebola affectent plusieurs pays de notre région et mettent à nouveau en évidence l'importance de renforcer les capacités de pays dans le cadre du règlement sanitaire international afin de prévenir, détecter et répondre aux urgences de santé publique. Comme démontré malheureusement durant la récente pandémie de COVID-19, les maladies n'ont pas de frontières et ne nécessitent pas de visa pour se propager. Du coup, ce webinaire sur la santé au point d'entrée et aux frontières dans un contexte d'épidémie de filovirus vient à point nommé et nous espérons donc que les thèmes choisis ainsi que le partage d'idées et de connaissances durant ce webinaire contribueront à garantir que nos pays respectifs soient mieux préparés pour faire face à une éventuelle urgence de santé publique. Donc, sans pour autant tarder, on va commencer avec quelques éléments de logistique. Next. Avant tout, j'aimerais signaler que cette réunion virtuelle respecte le code de conduite visant à prévenir l'inconduite sexuelle, y compris le harcèlement, l'abus et l'exploitation sexuelle. Next. Et si vous voulez prendre la parole, levez la main et on vous la donnera. Il y aura une traduction pour trois langues, le français, l'anglais et le portugais. Veuillez donc vous connecter à la langue qui vous semble la plus facile. Et lorsqu'il sera votre tour de parler, veuillez activer votre microphone pour prendre la parole. Next, Amarachi. Pour tout ce qui est des questions, veuillez mettre vos questions dans la fonctionnalité questions et réponses sur les sujets, les présentations qui seront faites aujourd'hui. Les réponses peuvent être apportées directement pendant l'événement, en privé ou en public, à l'intention des autres participants. Et j'invite aussi les panélistes à jeter un coup d'œil de temps à autre à la plateforme des questions et réponses pour pouvoir répondre directement aux participants, tout en sachant qu'on aura une session vers la fin où on aura des questions et réponses. Next. Alors, pour ceux qui aimeraient avoir les sous-titres affichés sur leur écran, veuillez appuyer sur l'icône que vous verrez en bas de votre écran, comme inscrit sur le PowerPoint que vous venez de voir. Next, Samarachi. Alors, la dernière chose, c'est que en participant à cette réunion, que ce soit en tant que participant ou panéliste, vous nous autorisez à enregistrer vos contributions et à partager les enregistrements via différents canaux à des fins d'apprentissage continu. Et les documents relatifs à cette session vous seront partagés quelques jours après ce webinaire. Donc, pour commencer, next. Je voulais juste vous présenter l'agenda de cet après-midi. Alors, on va commencer par une interaction sur Slido. Le moment venu, je vais vous inviter à scanner le QR code qui va être projeté bientôt. Et nous aurons trois panélistes aujourd'hui, à savoir le docteur Ninglang Wang, chef de l'unité santé aux frontières et rassemblement de masse basé à Genève, dont le terme portera sur l'introduction à la santé aux frontières et aux points d'entrée. Ensuite, nous aurons Madame Sarah Barragan-Montes qui nous parlera des orientations provisoires concernant la santé aux frontières et aux points d'entrée pendant les épidémies de maladies à filovirus. Et la troisième présentation sera une présentation faite par nos trois panélistes, à savoir le docteur Ninglang Wang, Madame Sarah Barragan-Montes et docteur Ibrahim Mamadou du Bureau régional Afrique. Et nous parlerons de la mise en œuvre d'interventions sanitaires aux frontières ainsi que la coordination avec les partenaires sanitaires aux frontières. Alors, sans pour autant tarder, nous allons commencer avec la première question sur Slido. Next. Next. Alors, séance, je vous prie de scanner le QR code et répondre à la question suivante. Quels sont les premiers mots qui vous viennent à l'esprit lorsqu'on parle de santé aux frontières? Alors, on donne 2 à 3 minutes. Alors, nous avons une cinquantaine de participants. Je ne vois toujours personne en train de répondre à la question. Ah, si vous avez du mal à scanner le QR code, je pense qu'on vous a envoyé le lien dans le chat. For those who'd like to have the question translated in English, I think the question is, what are the first words that come to your mind when border health is mentioned? Encore 2 minutes avant la clôture de... Voilà, je pense qu'on peut s'arrêter là. On peut déjà voir les thèmes, les thématiques qui reviennent le plus souvent, à savoir la surveillance, la santé, le règlement sanitaire international, le contrôle. Et je vois qu'il y a quelqu'un qui a marqué irréel. J'espère qu'à la fin de ce webinaire, on pourra convaincre la personne qu'il y a quelque chose qu'on peut faire quand même dans ce domaine. Donc voilà, j'invite maintenant le premier panéliste, Dr. Ninglan Wang, pour nous présenter son sujet sur l'introduction à la santé aux frontières et aux points d'entrée. J'aimerais rappeler aux panélistes que pour maximiser le temps de discussion avec les participants, veuillez vous en tenir au temps qui vous est alloué pour les présentations. À vous, Dr. Wang.
Merci Lionel. Bonjour à toutes et bonjour à tous. Merci beaucoup pour le temps et l'attention à ce sujet. Je vais présenter en anglais aujourd'hui. Okay, so could can we move to the next slide, please? Yeah, I will just speak very briefly for the current situation of the international travel. So just to understand the complexity vis-a-vis the volume of the international traffic, and then you will picture why the international travel and the traffic can pose a great potential of public health risks to the public. So you see that for the aviation sector, that for the past 10 years almost, that there's almost a 30% of the increase of international travel despite of the disruption during the pandemic. According to the data from the ICAO, IATA, and the UNWTO, we are seeing that the recovery of the international air travel, we are almost hit the same volume comparing with the prior pandemic period. For the maritime, and that's another picture. So we have the cruise ship, we have the cargo ship. Now, based on the data from the International Maritime Organization, almost 90% of um, um, the the goods and the cargoes are transported by the international maritime traffic. And there's also a big group of the population that needs a potential attention for the public health care and medical care. This is the group of the seafarers. So we have around 1.9 million seafarers that basically represent all the nationalities in the world. And they have a very different role and to protect the maritime health safety. Next slide, please. Can we move to next slide, please? Yes. So here I think that presents pictures that very much you can see in Afro. So you have very structured ground crossings, and you have open borders, and you have in the ports that basically plays a role of commuting, daily commuting. So that's another complexity group of the points of entry. Next slide, please. Just for to start, I see that in the Slido, in the survey in the very beginning, I see several participants. You already mentioned the international health regulations. So here, le premier message clé, it's around 10 parts of the international health regulations. Actually, we have more than half of the parts, the IHR parts, are talking about the travelers, the cargoes, goods, and conveniences, the ships, the aircraft, trains, and so on and so forth, and the points of entry. So when we say the border health and the points of entry, sometimes there is a question posed on our mind, what this border health means. So in the IHR, we do not have our clear definition of the border health. So you can't find in the definition in the IHR the border health, what the border health means, which is contrary to the points of entry. So you have a clear definition. However, as we just said, 5 parts of the IHR, the international health regulations, talking about the border health, which is the travelers, convenience goods, points of entry. So this is the first takeaway message I want you to keep in mind. And then with the table, you can see all the international health regulations articles talking about the issues, public health issues that could be very relevant to the border health and the points of entry. So I will not go to the details, but you will have the slides, and I will encourage you to peruse all these articles after the session. And that will give you a better picture of what border health means and what points of entry stands for in the framework of the IHR. Next slide, please. Okay, as we just mentioned, there is a definition of the points of entry in the context of the international health regulations. So points of entry is a passage for entry and exit of all the travelers, the cargoes, the goods, the conveyance, as we just mentioned. So that in this area, you will provide the health service, for instance, the water, food, the vector surveillance, and so on and so forth. So that's the definition under the IHR, which you can find in the very beginning of the International Health Regulation. Now, we always receive the question, because the designation is one of the mandatory requirements for the countries. So the country asks us, what could be the criteria for designate the points of entry? Because in my country, I may have 100 points of entry. How do you tell me which points of entry need to be designated, right? So there's a set of consideration, which is the criteria, looking at the density and the population near the borders, near the points of entry and around the points of entry, what the volume or the frequencies of the international traffic, the ships, how often the ships coming and the ships coming from where, aircraft, the trains, and the communities passing the borders. So we are looking at all the volume and the frequency, and what are the health risks around the points of entry or associated with the aircraft, the ships, the trains, and the people crossing borders. What's the country's coping capacities? For the land borders, how do we do the joint designation or have a multilateral agreement for public health risks reasons? And what are the epidemiology in and around and the points of entry? And then, of course, there's a multimodal transportation. Sometimes people cross the borders to take the flight, or people coming from the cruise ship, and then they pass the borders to another country. So those are the complexity. And then we need to think about when we go through the designation process. Now, for the airport and the seaport and the IHR, it's mandatory for countries. Le deuxième message clear. So for airport and seaports, this is mandatory for the country to designate. However, for the ground crossings, this is optional, really based on the risks that you perceive on that specific ground crossing, and then you will decide whether this should be designated. Next slide, please. So some of the, let's say, the key messages from the international health regulation, which represent the mandatory requirements for the country to comply with the international health regulations. One is the designation we just mentioned, designation of the points of entry. The second is identify the competent authorities for those designated points of entry to apply the health requirements, will help provide the health service as per the IHR requirements. And then the third one is to submit to WHO the list of authorized ports, the ports authorized by your country to issue the ship sanitation certificates. I had a quick look on the data. So you can see that at the right column, we have this color-coded places where you see the Afro, you have 11 countries in your region who have already submitted the list to WHO. However, knowing that there are more than 50 countries in Afro, despite of the landlocked countries, there are still a number of countries who haven't sent to WHO this list. C'est le troisième message clear. So I think that we need to encourage the country to submit to WHO this list, which we will subsequently to publish on the WHO website. Next slide, please. Okay. Now, moving on to the capacity building, which are the requirements under the IHR. There are three pillars for this type of the POE capacities. One is the, oh, sorry, I haven't finished that. The key obligations for the countries. And the fourth one is to build the 400 meters vector-free zone around all the operational areas in and around the points of entry, and then have the capacities and during the emergencies to comply with WHO recommendation. For instance, sometimes during the fake time, WHO may recommend exit screening. That's our example. So how do we set up the map exit screening? How do we communicate with the partners and the travelers? Those are the arrangements that the country needs to have the capacities to set up, and then provide WHO the information that relates to the travelers, cargoes, goods, convenience. If there's public health risks identified in the at points of entry at the borders, this might need to supply, share with WHO within 24 hours. So if the national focal points reach out to the points of entry, they wanted to have more information, we need to have that capacity to provide that information. And then, of course, that because there are other countries who share the border with your country, this might need to looking at the collaboration, cross-border collaboration and information sharing. Next slide, please. Yeah, now coming back to the capacity building for the IHR, which is the mandatory requirements under IHR. So we're looking at three major pillars for that capacities. One is the coordination and the communication. I think after many outbreaks in country, I see more and more often that we have a very robust system for this coordination and communication between the points of entry and the national or local communities, health authorities. So just wanted to refresh and what we need to consider, which is the coordination and communication horizontally between the points of entry stakeholders, between points of entry and the local communities, and then vertically. Vertically, we're talking about, yes, the information between the surveillance information between the POE and the national surveillance and response system, and so on and so forth. So this is just to give you our snapshot how that coordination communication, the interaction between the horizontal and the vertical levels. Next slide, please. So another second pillar is the capacities for routine times, which you can find in the IHR Annex 1B. We're talking about a set of capacities, including the medical care, the safe transportation of suspected cases, and the interview with the close contacts, train the personnel for shipping inspection, and other POE environment, and then to safe POE environment, which means that you provide safe water, food, waste management, vector surveillance, and control. Then the third pillar is the emergency capacities, which you also can find in the Annex 1B. So that's very similar to the capacity in routine times. However, one very specific for this set of the capacity is to develop a public health emergency contingency plan. Depending on the different types of POEs, the contingency plan needs to be very much integrated into their environment. Take an example. I think that in Afro, this is very typical. For any land border related contingency plan, the border communities, how that public health risks and their capacities all need to be taken into consideration, and the communities need to be involved in the development of this type of contingency plan. Next slide, please. And then another point, as we just mentioned earlier, that the requirement for the shipping inspection and ship sanitation certificate, because ship is a very specific environment, and when they navigate across different countries, how we ensure that there is public health safety on board the ships. So there are two documents in the IHR. One is the Maritime Health Declaration. I think this is a very much the mandatory requirement for almost all the countries for the incoming ships. The other one is the ship inspection certificate. Maybe you can just click next, so we'll have the set of the requirements for the ship inspection certificate. Can you click, Hamarachi? Yeah, thank you very much. So this is the certificate to replace the old D-rating certificate. Starting from 2007, the certificate is applying all hazard approach. So you will see there across the ships, they might have 13 areas of inspection. And for all the ships engaged in international maritime traffic, they need to present a valid certificate when they arrive at the one international seaport. And this certificate is only valid for 6 months. That's why when the countries you have submitted WHO authorized the list of authorized ports, those ports can provide the house inspection service to the ships who request the renewal of ship sanitation certificate. Otherwise, you won't have that right and to inspect the ships and to renew their certificate. Next slide, please. Yeah. And a very light touch on the eSPAR, which is the annual reporting tool as a national focal point. Some of the colleagues here might coming from MOH. You might be aware this is an annual reporting process. The countries need to report their progress of the implementing the RHR to the Water Health Assembly. So this is the tool. And now for the points of entry, we have 3 indicators. One is the indicator for routine capacities, and the other one is for emergency, and the next one is for the risk-based approach for decision making at the national level, the local level for the international travelers. So this is very well presented during the COVID-19 time when you need to decide what measures need to require the travelers, and so that's the decision making process. Next slide, please. Here is our package for providing WHO assistance to the countries to help you to sort of speed up your process of meeting the RHR requirements for routine times and emergency times. So you can see there are a variety of the activities, for instance, the evaluation assessment of the POE capacities, to any capacity building activities, the training, simulation exercise, and then the population mobility mapping, which can help you to strategically identify the key populations, the key pathways of cross-border pathways to prioritize your health interventions. And then, of course, the other is the response, your contingency plan to support you develop your contingency plan for public health emergencies. Next slide, please. I think I only have 2 or 3 minutes, so I need to speed up. For WHO, we are working very closely with the other international organizations and the Civil Aviation Organization, Maritime Organization, IOM, to look at, synergize our legal instrument when it comes to the public health issues around the borders. So here are some examples that we had during the COVID-19. So we can harmonize our messages to the travelers, to the staff working at the points of entry. So we have a very harmonized public health advice and the considerations to respond to the health emergencies. Next slide, please. The last slide, but not the least, definitely. Recently, we have, WHO has, it was the last year, published this HEPA, Strengthen Health Preparedness, Readiness, Response, and Resilience. So this is a global architecture. They have 5 pillars. And now talking about the border health, we're actually related to at least three C's. One is the cross-border or the collaborative surveillance, because of the cross-border surveillance plays an important role for the joint preparedness and the response to prevent international spread of diseases. And the other one is the create public health interventions with the communities for the public health actions to contain the public health risks. The third one is the emergency coordination. Because of the multi-sectoral, multidisciplinary nature of the border health and points of entry, we need to work with many sectors and to have more coordinated response. So here are the three major capacity capabilities that we need to work together. And then the other one is the GPW 14 on the global health strategy for 2025-2028. There is a one component, the fifth component for the prevention and the mitigation public health risks for all the countries. And so with that, you can see 5.1, 5.2 is very much related to the implementing the international health regulations, in which points of entry, border health is a crucial a component. So I will also encourage you to read a little bit on these two global frameworks, because that could determine our future work in the next several years. And I think that will gives you a different picture that about border health and the points of entry's role here. So I think I will stop here. I think that's the last slide. Yes. Thank you. Merci beaucoup pour votre attention.
Merci
Back
beaucoup,
to you.
Dr. Huang, pour votre présentation et je pense qu'on a encore 3 minutes avant de commencer la prochaine session. S'il y a une question brûlante ou il y a un commentaire, je peux prendre un ou deux commentaires ou une ou deux questions dans les 3 minutes qui restent. S'il n'y en a pas, on peut commencer avec la deuxième session, mais avant cela, on aura une interaction Slido. Est-ce qu'il y a une question brûlante chez les participants? Une question ou un commentaire? Je ne vois pas de questions. Alors, sans tarder, on va entamer la deuxième session, mais avant cela, on va répondre à la question qui est projetée sur le Slido. C'est la même consigne. Veuillez scanner le QR code et répondre à la question suivante. En tant que personnel technique, quelles questions ou orientations vous sont souvent posées concernant les points d'entrée et la santé aux frontières? Nous avons 3 à 4 minutes pour cette question. Pour ceux qui ont un problème pour scanner le QR code, je rappelle que le lien a été envoyé dans le chat box. Encore 2 minutes. Merci beaucoup à tous ceux qui ont pu répondre. Je rappelle que si vous avez des questions, vous pouvez mettre ça dans la partie Q&A. Et je vois bien qu'on a quelques mots qui reviennent assez souvent, les voyageurs, surveillance, point d'entrée. Il y a une autre question que j'aimerais que les panélistes répondent, c'est quoi faire lorsqu'on a un animal qui est infecté au niveau des postes des points d'entrée ou bien aux frontières. Et j'invite les participants aussi à ne pas hésiter à mettre leurs questions dans la partie qui est réservée. Voilà, donc c'est la fin de cette interaction Slido. Maintenant, j'invite Madame Sarah Barragan-Montes pour nous parler du thème suivant. À vous.
Merci beaucoup, Lionel, et bonjour à toutes et à tous. Je ferai ma présentation aujourd'hui en anglais aussi. So, in this presentation, I'm going to introduce to you the interim guidance on border health and points of entry during filovirus disease outbreaks. Next slide, please. In particular, I'm going to focus on two specific sections, which are linked to the policy considerations of this guidance document. And then Dr. Wang will proceed afterwards with some of the technical considerations that are also included in this document. The two sections that we're going to be looking at in this presentation are first, the travel advice, and second, policy considerations with regards to what we call often travel restrictions, as well as syndromic entry and exit screening. Next slide, please. In this slide, you can see a snapshot of the guidance document. It was published in October of 2024 in the context of the Marburg virus disease outbreak in Rwanda. However, the guidance document applies to all filovirus disease outbreaks. And as I mentioned, it includes both policy and technical considerations on all the main aspects that need to be addressed during FVD outbreaks for border health and points of entry. You can also find in this slide the link to access the publication. Next slide, please. So moving on to our first slide, the travel advice, there are three main target groups that we need to think about when we develop a travel advice. The first target group are travelers in affected countries. And here the key advice from WHO is to recommend that the following individuals avoid any travel, including internationally, until they no longer constitute a public health risk. which of course should be determined by a healthcare practitioner or a public health officer. And this includes the following individuals: all suspect, probable, or confirmed cases, contacts of cases, which should be under health monitoring, as well as anyone with signs and symptoms that are compatible with the case definition. So this is for travelers that find themselves in affected countries or areas by the outbreak. Next slide, please. Moving on, the second target group that should be considered in travel advice are travelers that are planning to travel to affected countries or areas. So they find themselves somewhere else, but they are planning to undergo a travel to affected countries. Here, the advice that should be included is to, of course, first of all, stay up to date on the evolution of the outbreak and the epidemiological situation. Second, to avoid any contact with anyone that is showing FVD symptoms, or as well with contaminated materials and surfaces, and particularly to stay away from infected people's bodies, including during funeral, given the high risk of these situations. On these slides, you can find some examples that I have included of travel advices. The previous one included an example of a travel advice published by the government of Tanzania during the ongoing MVD outbreak. And here in this slide, you can find a travel advice that is also published in the context of the MVD outbreak in Tanzania, this time by the US CDC. Next slide, please. Finally, the third group that should be considered when we develop a travel advice are travelers that are themselves already in the affected countries or areas, and they are returning from those affected countries or areas. Here, the advice is targeted in particular to those travelers that return from affected areas within the previous 21 days and who feel sick with early symptoms like fever or bleeding, and they think they may have been exposed to the virus. In this case, the advice should be to isolate themselves, to contact a doctor right away, and to share their travel history, as well as information on any high-risk situations that they have found themselves in, as well as information about any person they have been in contact with. In this slide, you can find another example, this time published by the UK government, again in the context of the MVD outbreak in Tanzania. Next slide, please. Moving on from the travel advice, another key issue that always comes up when there is an outbreak of a filovirus disease is with regards to what we often refer to as travel restrictions. I apologize because for some reason, the format of the slide has changed, so you cannot see all the text here, but I will go slowly through it and we will share the presentation after. So first of all, the main thing that we should remember is that there is no definition in the IHR for what we often refer to as a travel or a trade restriction. This is a term that we often use to refer to health measures that significantly interfere with international traffic. And significant interference is actually very well defined in the IHR, particularly in Article 43 of the IHR, and it is defined as the refusal of entry or departure of international travelers, baggage, cargo, containers, conveyances, goods, and the like, or their delay for more than 24 hours. Meaning, if there is a health measure that implies the refusal of entry or departure or the delay for more than 24 hours, we refer to those health measures commonly as travel restrictions. It is also important to note that there is an obligation by states parties, by countries, to inform WHO if they implement measures that interfere with travel and trade. In this case, the obligation that was agreed in the IHR is that countries should inform about such measures to WHO within 48 hours of implementation, including the public health rationale and the relevant scientific information for such measures. Next slide, please. Another key question that often comes up during outbreaks of filovirus disease is with regards to entry and exit screening. Dr. Wan will go later into some of the technical aspects that need to be considered when implementing exit and entry screening. But here we wanted to clarify with you before what is WHO's policy position with regards to the use of these measures during outbreaks of filovirus diseases. So WHO's position, as you can see there at the very beginning, is that exit screening may be implemented at points of entry or across borders in affected areas with the aim of preventing the exportation of the disease. In addition, entry screening may be implemented at points of entry or across borders in high-risk areas with the aim of reducing the likelihood of importing the disease. You may see on the slide that the word may, peut-être, is highlighted in bold, and I will explain in the next slide why this is the case. In addition, if a screening is implemented, exit or entry screening, it is always important that this measure is informed by a risk assessment, which is regularly reviewed to make sure that the measure helps to reduce the risk of spreading the disease while minimizing the socioeconomic negative impact that it may cause. Exit and entry screening is also recommended to be coordinated among neighboring countries with the objective of sharing rapid information, of coordinating the response, and of using resources efficiently in a way that we do not duplicate efforts between two neighboring countries. Finally, it is also important that screening is conducted with respect to the dignity, human rights, and fundamental freedoms of travelers, as per Article 32 of the IHR. Next slide, please. Now, the reason why we highlighted the word may in the previous slides, I will explain that in this slide. WHO last year conducted a systematic review of the evidence, the scientific evidence that is available on the effectiveness of syndromic entry and exit screening for epidemic-prone diseases of travelers at ground crossings. We partnered with a university and convened a group of technical experts, a guideline development group, to review the quality of this scientific evidence. And unfortunately, the expert group concluded that there is insufficient scientific evidence available to issue a strong recommendation either for screening or against screening for epidemic-prone diseases. For this reason, it is that we say that countries may use exit or entry screening in certain situations, such as in FVD outbreaks. And more importantly, we also recommend that as much as possible, countries collect data on the effectiveness, cost effectiveness, and impact of screening measures so that we can increase the body of scientific evidence that we have in this field and hopefully develop a recommendation in the future. The results from this systematic review are published on WHO's website. You may see an image of the publication on the right and the link where you can access it at any time. Next slide. That is it for me for now. Merci de votre attention. Thank you.
Merci beaucoup, Madame Sarah Barragan. Est-ce qu'il y a des questions importantes avant la transition à la troisième session? On a 5 minutes. Vous pouvez lever la main et je vous donne la parole si vous avez une question brûlante sur l'aspect pratique concernant la santé aux frontières, comme présenté par Madame Sarah Barragan. Je ne vois pas de questions dans le Q&A box, donc juste une question à Dr. Sarah Barragan. Dans le contexte africain, je pense que ça va être discuté par notre collègue Mamadou. On a la porosité de nos frontières et l'aspect pratique que vous venez de mentionner, c'est très bien. Mais au niveau, en réalité, pour la région africaine, il y a encore plus de défis à ce côté. Et je comprends bien que vous demandiez au pays de faire une étude d'évaluation pour voir l'efficacité des mesures de dépistage qui pourraient être mises en place dans les points d'entrée. Je pense que pour ne pas anticiper la réponse, juste avoir une réflexion de votre part sur comment cela devait être fait au niveau de la région africaine.
Thank you very much, Lionel. This is a very good question, and indeed, I think it anticipates some of the topics that are going to be covered in the next presentation as well. We know that porous borders, open borders that are not administered, can present a challenge for outbreak response. And we do know that in the context of limited resources, we cannot ask for all points of entry to be able to implement all measures. It is for that reason that when an outbreak takes place, and it is important that we distinguish here between preparedness and response times, when we are in response times, it is very important that we implement measures always informed by the risk assessment. So where is the risk taking place? And also in the context of border health, we will speak later about the importance of understanding population mobility dynamics so that we can prioritize areas and districts according to the level of risk. And when necessary, implement measures at the points of entry or points of control, and also with an emphasis on cross-border collaboration between the different neighboring countries. I know that my colleagues are also going to touch upon some of these issues later. So let me see if any of them would like to complement this answer at this time, or they prefer to do so later on. Thank you.
Merci beaucoup. Donc, je pense que sans transition, si vous permettez, il y a une question du Togo. À vous la parole. Est-ce que vous pouvez...
OK.
D'accord.
Bonjour à tous. Très ravi de suivre cette formation. J'ai deux préoccupations. D'abord, lorsque nous parlons des frontières, il y a un indicateur phare. C'est le temps que les voyageurs mettent pour faire la traversée. Maintenant, comment concilier, par exemple, la surveillance au point d'entrée avec les testings et le temps de passage aux frontières. Ça, c'est la première préoccupation. La deuxième préoccupation, lorsque on veut aller vers l'intégration sous-régionale, est-ce que le fait de mettre les testings, la surveillance au point d'entrée, multiplier par exemple cette surveillance au point d'entrée, est-ce que on peut allier l'intégration sous-régionale et la surveillance au point d'entrée, à l'instar par exemple des pays développés où on traverse des points d'entrée ou bien des frontières sans qu'il y ait un check-in au niveau de ces frontières ou bien points d'entrée. Je ne sais pas si je me suis fait comprendre. Merci beaucoup.
Merci beaucoup, chers collègues. Le nom, c'est Dovi, c'est ça? Ou
Oui,
bien
oui.
ça, c'est... D'accord. Alors, je vais laisser 3 minutes aux différents panélistes pour essayer de répondre à cette question. S'ils pensent qu'on peut le faire maintenant, sinon, ils peuvent essayer de le faire durant leur présentation. À vous, les panélistes. Dr. Ibrahim Mamadou, euh, ou Dr. Wang.
Thank you very much. I think that some of the responses might be covered in my presentation and also in Dr. Mamadou's presentation, because we really looking at the specificities of the land borders as our country colleagues have just mentioned, because the open borders, because of very short duration, passing that physical points of entry, how that surveillance can be achieved to facilitate the early detection of the cases. I think that when we in my first presentation we mentioned the difference of points of entry and the border health. I think that's another, I would like to emphasize again, when we say the points of entry, we indeed that mentions that the short duration when the passengers passing the borders, it's very difficult to identify unless the exhibit, the signs and the symptoms in complying with certain diseases. Otherwise it's very hard to detect. So for the surveillance at the borders, we're really not only looking at that episode, but we are also looking at the prior to travel and the post travel. I think COVID-19 pandemic response has give some inspiring ideas, and when we do the screening at the borders, maybe that's not so effective, of course, based on the disease nature, but how we combine the really build the integration of the or the cross-border collaboration, and to set up the standard data set for facilitating the surveillance information sharing across the borders, and then how we identify the opportunities in the communities when there is a health alert. You already can mention that, you already can pass that to the borders. So there are things that we need to consider the difference between the land borders and the other type of the POEs. Now, I wanted to highlight one. I know that I don't want to take too much of that time. We together with Africa CDC and the WHO, IOM, Africa CDC, we developed together Africa continental cross-border surveillance and cross-border information sharing as a strategic paper. So that document actually highlight the areas where we can facilitate together with the state parties who will be involved in the border health preparedness response for cross-border surveillance and information sharing. I would attach that in the Q&A, so you will get the link for that. And hopefully in the next presentation, we will provide more details. Thank you.
Merci beaucoup, Dr. Wang. Je pense que tant que vous avez encore la parole, je vous prie donc de continuer avec la session suivante sur l'opérationnalisation des interventions sanitaires aux frontières fondées sur les risques lors des épidémies de maladies à filovirus, en coordination avec les partenaires. À vous la parole.
Merci beaucoup. So, okay, I will ensuite sleep. I will present the, the key considerations for the filovirus outbreak preparedness response at borders. As I think Sarah has already touched upon a few points. Next slide, please. Sorry, Amarachi, can you move to the next slide? Oh, yes, thank you. The next one. Sorry, the next. So here are the next one, please. Yes, so here are some key considerations that we would like to call your attention. Sarah has mentioned in some of your in her presentation about the traveler information, how we provide the public health information and advice in all the languages. I think this is definitely you can work our countries we can work between the points of entry and the RCC colleagues and to make sure that the language are tailored to the local communities based on the culture, based on the language, based on the literacy. So this is the one point I think this regardless of the diseases, this is always a action to be implemented for points of entry in terms of educate the public. The second is really our sort of a house promotion. However, is the advice for the suspected cases, confirmed cases, probable cases, and their context. And this is crucial because for the suspected, probable, and confirmed cases, they are supposed to be isolated. So in that case, they should avoid international international travel. And then for their contacts, they should be also put under public health observation. So in that case, they are under health monitoring. So in other words, they should also avoid engaging in international travel. So these are the information that as a public health authority and the POE authorities, they need to pass that to the international travelers. And then set up hand washing stations. I think, and with the disinfections, the soap and the water and the alcohol-based hand sanitizers. This is normally a well-established practice at airports and the seaports. However, at the land borders, we do see oftentimes when we go for the land border assessment, this is not always well set up there because of lack of the access for the materials, access for the infrastructures. So I think that's a point that we need to also take when you look after your POE preparedness and response. And then for the filovirus, and if there are any if any cases or suspected cases detected at borders or at aircrafts, ships, trains, or people passing the borders, and the international contact tracing should be immediately initiated to make sure the contact, the transmission chain can be disrupted. Next slide, please. Now, in the very beginning, the survey, I see that many colleagues you have typed in the screen on enhanced surveillance, the screening, setting up the screening, and set up the isolation places and the safe transportation and the training, the human resources, and how to address the cross-border surveillance and collaboration. Many of the points already hit there. So I think I can just go through very quickly. I think these are the critical points for the capacity building to address the points of entry issue, especially in those land borders. So when we talk about the surveillance at the points of entry, oftentimes, especially for hemorrhagic filovirus, the screening continues to be our useful tool and for the early detection of suspected cases. And then the other one, as one of the colleagues already mentioned, the integration of the surveillance system between the countries share the borders, and then for setting up the isolation plates. So that isolation facilities need to be away from the normal passenger flow to avoid the cross-contamination, and then to identify in the the health care facilities for the medical referral of those suspected cases. And then training POE, I think this is continues to be a very challenging point because of high turnover of the POE staff. Sometimes it's a very really like surge capacities, so they need to be trained for the signs and symptoms, identification of signs, symptoms, understand of proper use of the PPE when they do the interviews with the suspected cases, and then also to there are other to have an oversight for the water, food safety, and then the safe disposal of the medical or infectious wastes. And then the other one is to conduct the population mobility mapping, which Sarah will elaborate a little bit on on her presentation. This is a very instrumental tool, however, a little bit complex process because we need to engage the communities, engage the relevant stakeholder to do that. However, with one time you do this, this will present a good foundation to refine for the future preparedness and response. The purpose of this exercise is really working for the borders frequently used by the countries sharing those borders for their daily commuting, for their socialization with the other communities across the borders, and so that will give you our overview of the critical points that those cross-border movements will take, the pathways, and then where the points of the convergences, where who are the main populations from that community. So and what are the purpose for passing the borders. So that give you some information for the risk assessments to determine the health interventions where you can optimize your investment of the health interventions. I know many of the Afro countries you have done systematically this type of exercise. I hope that has been already integrated in your risk assessment. Next slide, please. Now, have a little bit more words on the surveillance in terms of the screening. So we know that for the screening, we have, house decoration. We could do the visual observation. Of course, one really a caveat is that to maintain the distance. So make sure that distance, keeping distance becomes a new social hello instead of shaking hands. Then next slide, please. For the entry and the exit screening, I think we will just speak a few words to clarify in what conditions that we use the entry screening, what conditions you use the exit screening, what are the key, let's say, considerations for that. Knowing that the surveillance at points of entry at that episode, including points of entry and, of course, conveniences. So this presents a routine surveillance activities in order to have an early detection, and then we can alert the national surveillance and response system because we have the information, first-hand information from the travelers passing borders, from the ships, aircrafts, trains, buses. So this information can serve as a good health alert for the system. Now, talking about exit screening is very much used for the countries where outbreaks occur. To avoid or to prevent the exportation of the diseases, exit screening can be used as one layer of the health mitigation measures. So normally, the screening will include the primary screening and the secondary screening. I see Dr. Mamadou shared in the chat the exit screening, entry screening guidances published during the EVD outbreak in 2014 and 15. Although we're coming across, different diseases, which is still filovirus. However, the technical principles of setting up those exit screening, entry screening can be still used in the current outbreak context when it comes to the filovirus. Now, for entry screening, so that's normally, it's always a very debatable when we say the entry screening. However, we recently published our guidance for the screening of epidemic-prone diseases at land borders. So that gives the evidence review result is um, we do not see really huge, robust evidence to support the entry screening in many epidemic-prone disease contexts. However, we do not see either the negative consequence of implementing this entry screening in the epidemic-prone disease, which includes the filovirus, a group of filovirus diseases. So for the entry screening, what we normally consider is that it's a good supplementary step with the exit screening. So if the exit screening is implemented, and then entry screening will add more effectiveness into that to serve the early detection of suspected cases. However, when we set up an entry screening, we know there's a resource requirements. So I think those are the things that should be already taken into consideration when you start the planning phase. Next slide, please. So here is the screenshots that we take from the entry screening, exit screening guidance for the EVD. As we said, the principles of setting up those screenings can be, presented in that guidance can still be applicable to the current outbreak context. However, I just wanted to highlight one questions that we always receive when the country started to think about the setting up the screening process, which is the location, because we know well, at land borders, it's much more evident because many times it's open borders. But for maritime and the aircraft side, aviation side, the location and time to conduct exit screening, entry screening could have an impact of the effectiveness. Okay, so I was reminded to speak a little bit slowly. Okay, thank you for the reminder. Now, thinking about the exit screening, we need to think when the travelers coming to the points of entry, we need to do it as early as possible, the exit screening. So in some cases, in some countries, normally they do at the very early entry of the to the POE. So in this case, only travelers are allowed to enter the POE. That will avoid the cross-contamination between the potential suspect cases and the public. But as some countries, they prefer to do it before the security clearance. So all the people can come into the hall of the POE, but the entries of the exit screening will start at the entry of the security line. So this is just an example, but you will get more detail from that guidance. Next slide, please. Now for the entry screening, that's also a very similar principle. We need to do it as early as possible. So when the travelers coming out from the aircraft, ships, trains, or just arrive as a pedestrian, arrive at the borders, the entry screening should be really at the front line of the POE. And I see many times, especially at the land borders, the POE staff, the stations are not all the times at the front line. This will create a little bit, the potential opportunity for contamination. And if the screening is not at the front line. Okay, so we can move to the next slide, please. Now, the other point in the very beginning of the survey, colleagues also identify this, set up the isolation room at the points of entry, so that will include the consideration of identify a separate room or separate areas to temporarily put isolated, basically put the suspected cases until they can be transported safely by the ambulance. This is raised, one question is really the availability of the ambulance. Oftentimes we also hear that the ambulance, normally we use the public ambulance in the country, the community, where the communities that often use. So that could create some of the shortage of the ambulance when we really need it at points of entry. So that really requires some innovative approach, for instance, co-sharing the cost, or engage the POE operators and to rent or to buy ambulance during the preparedness phase. So this need to be really taken into consideration. And yes, that relates to safe transportation of the suspect cases. And then the other is the clear protocol for referral of the suspected cases, especially in the IPC requirement for those drivers and for people who accompany those suspected cases to the medical care facilities. Next slide, please. Yeah, so a few more words on the consideration, the IPC. As we already mentioned, the importance for the hand hygiene and sanitation. So we need to really to educate or put up the stand for this type of education, and also to set up the hand washing station or provide the alcohol-based hand sanitizers, and to make sure that there are means for the travelers and to wash hands. Then maintain the good stockpile of the PPEs. This is also somehow not always considered as when the communities and the border communities start to prepare and their preparedness response. We need to always to remind at the POE staff, we need that set of the PPE stockpile to make sure when this is there when it's needed. And then the other one is to provide the waste bins, which is color coded to accommodate the medical waste, infectious waste, and to make sure their disposal is complying with the your protocols or the regulations in the countries for disposal of the infectious wastes. Of course, then all the time, the staff needs to be trained, needs to be reminded of the signs and symptoms, and reminded the high hygiene and the safe disposal of the infectious wastes. Next slide, please. Yeah, it's almost come to the end of my presentation. The last slide is about the cleaning and disinfections. Sometimes at land borders, I think we have less resources. So we will address that. If you do not have the prepared or commercialized disinfectant, we might need to prepare that every day. And we need to prepare every day and discard every day, because this could be, the product is no longer efficient. Then for the cleaning and disinfection, we always need to bear in mind that we have to focus on the high touch areas. For instance, all these door handles or the counters or the surfaces that the travelers use to touch. And then when we talk about the self-preparation of the chlorine-based disinfectant, we need to always keep in mind the label, the concentration, label the preparation time. So the next staff will understand, when this is prepared, what's the concentration, how properly this can be used. And then there is a golden rule as well. When we do the cleaning and disinfection, we need to clean first, and then followed by disinfection, because that will increase effectiveness of this disinfection. And clean all the tools, equipments from the cleaning area first and moving to the dirty area. So this is again just to avoid the cross contamination. And then all the equipment, dedicated equipment should be clean and disinfected after each use. And then proper handling and disposal of potentially infectious waste. This not only for the staff, but also for the travelers. So they will understand that why they need to do the hand washing and when they need to do the hand washing and how. And the same applied for the disinfection. Yeah, the last but not the least, the safe disposal of the medical wastes. And this needs to really comply with your national protocols, national legislations. Again, I think this is at the airports and the seaports. This is normally very well regulated. However, at land borders, because of the shortage of the resources and then the training of the staff, the surge capacity, the surge staffs, this might not be always very evident for everyone. So I think those are the things that we really need to, it's kind of a point en attention. We need to really keep in mind. I think for the sake of time, I will stop here. Happy to answer any questions. Thank you, and back to you, Lionel.
Merci beaucoup, Dr. Wang. Je pense qu'on peut déjà entamer avec la présentation suivante. Avec, c'est Sarah Barragan, je pense.
Exactly. Thank you so much, Lionel. Colleagues, I will present to you just a couple of slides where we wanted to address a bit more in detail the issue of population movement mapping and its role in assessing high-risk points of entry and cross-border areas, which is a topic that has come up indeed before in one of your questions. Next slide, please. So the understanding of population movement dynamics should inform, as Ninglan has mentioned before, the geographic location of public health interventions during outbreak response, including the implementation of border health measures when these are necessary. This is particularly relevant in the context of open and porous borders indeed. Within WHO, we had several discussions on how this issue is being addressed internally. We realized that there is a multiplicity of tools and approaches that are already being used by partners that are promoting very good work in this field to map population mobility. I am sure many of you will be familiar with the population mobility mapping of IOM or the PopCap tool of the US CDC. And these are indeed two organizations that we work very closely with on these topics. However, we did realize throughout the different outbreak response operations that sometimes data on population mobility is collected in an ad hoc manner when there is an outbreak occurring. And we think there is not enough legacy that is built afterwards to inform future response operations so that we work on mapping population mobility dynamics in a more sustainable manner. In addition, part of the problem statement within WHO is the fact that we did not have a systematic approach for the support to ministries of health and partners in this area. And in addition, there are new technologies such as GIS that we think could be explored even more for use in this particular field. Next slide, please. As a result of all these conversations within WHO, we established a working group within our WHO Health Emergencies Program, but also in collaboration with other units, particularly the WHO GIS Center, with the aim to explore and address this gap and see whether we could standardize the way WHO and partners and ministries of health use population mobility mapping for outbreak preparedness, readiness, and response in a more sustainable manner. At the moment, we are working on the development of an interactive dashboard using GIS technology that is aimed to inform public health risk assessments and readiness and response operations. Our goal is to bring together into that dashboard the data from open sources that is of most use to map target populations and travel routes, cross-border travel routes, and also to provide different access to such data so that countries can also include into these dashboards the results from different exercises being done on the population movement mapping, with the capability of restricting access to that information in case it is sensitive. The final aim for us is really to use this connectivity analysis to inform risk assessments. And at the moment, we are in the process of identifying pilot countries that have done already such exercises or are interested in doing so, but would like to benefit from such an electronic dashboard, electronic tool that would pull all of this data together for use, not just in ongoing outbreaks, but also in future similar situations. Next slide. That's all we wanted to tell you for now on this topic. We are aware that it is a topic that generates a lot of interest, and we're very happy to speak further about it during the Q&A session. But for now, over to you, Leona.
Merci beaucoup, Sarah. Je pense que sans tarder, on va passer la parole à notre collègue Dr Ibrahim Mamadou de la région africaine pour nous parler des outils d'évaluation de la santé aux frontières destinés aux points d'entrée. Over to you, Ibrahim.
Thank you very much, Leonel. Thank you, colleagues and participants. So I will just be touching quite quickly. Several of the aspects have been discussed by our colleagues as they were presenting. I will just touch on some slides and skip over some. Kindly forgive me, because of bandwidth issues, I will switch off my video to avoid the sound being disconnected. So on your screen, you will be seeing that there's 3 documents there. Some of them may be familiar to you. The one on the left is the International Health Regulations, which guides and is the foundation for all of the work we do, especially when you notice with that book, as Ningland has mentioned, most of those regulations talk about border health and points of entry, as well as some other aspects. In the middle is the cover of our guidance for assessment for core capacities for designated airports, ports, and ground crossings. This is really a very important tool used in our process of designation. As you do know, as member states, when you designate a point of entry, you are committing to the rest of the globe that you are going to build, or you have the capacities in those points of entry to respond both in peacetime, that is routine activities at the points of entry around vector control, water safety, food safety, as well as the capacity to respond in emergencies to any emergency event that could be a potential fake. You're making that commitment, and that document gives you a screening, not a screening, but an assessment tool in very big detail on what it is that will be needed if you choose to designate a point of entry. The last document on the far right is a guidance document on capacity building on ground crossings, which will be, I'll touch in more details as we find many of our participants in the region are not so familiar with this document. Next slide, please. So just a reminder, most of us know this, but IHR monitoring and evaluation includes state party annual reporting, the joint external evaluation, after-action reviews, and simulation exercises. The first two really talk to a lot of what countries are doing as per accountability to the globe on reporting what capacities they have. And I'm sure many of your member states have just concluded the process of submission of your mandatory annual state party reporting, which includes you stating which points of entry are designated in your country. We are also in the process of the second round of joint external evaluations in Afro. Quite a number of countries have done this, and you've noticed that the POE pillar, when you're the POE technical area, when you're assessing, also has a new indicator asking on risk-based assessments. After action reviews, as you know, these are assessments of functionalities, which you do, and now you know there are early action reviews, intra-action reviews based on lessons from COVID, and of course the after-action reviews to document best practices or gaps after you've responded to an emergency. Very important to our processes in points of entry and border health is testing what capacities you think you have. And this speaks to simulation exercises, and it speaks to what is the ideal, how should it work, does it work, and how can you improve. When you're in peacetime, you do an exercise to test your capacities for when there is some real event. So I will go over, next slide, please. So you should be looking at the assessment tool, this orange and white document, and the links will be shared with you after the webinar. This document assesses your capacities for designation, but we don't say you should limit only assessing the points of entry that you want to designate to using this tool. You can also use it in other points of entry just to track where your gaps are. But the importance of this tool is, as you finish doing this, as I said earlier, you're committing that you're going to build all the capacities being assessed there. So you need a plan of action of how to improve your designated and even non-designated points of entry after you do this assessment. Next slide. So that tool has 3 sections: a section on coordination, communication of event information, and adoption of health measures for control. Then it has a second section on core capacity requirements at all times, your routine capacities. For example, in airports, do you have vector control in the 400-meter radius around the airport aerodrome? And then, of course, the capacity requirements for responding to an event that may constitute a public health emergency of international concern, which is the third section. It feeds into JEE indicators, and many countries are in the process of doing their JEE. Next slide. So I will go into a bit more detail on the ground crossing strategic risk assessment. And I just remind you that the previous assessment tool, that document I showed, is the guidance document. The tool is actually a very big Excel document, which many countries have been able to use. This also is a guidance document on an Excel that does a strategic risk assessment for ground crossings, or what we call land borders. Next slide. So why do we have this separate ground crossing strategic risk assessment? Ground crossings are a bit special in the IHR. This rationale is that while IHR 2005 stipulates that your countries, or we say state parties, should designate airports and ports, which is seaports, to meet the core capacities. That is Article 19, 20, 21. IHR is a bit more flexible on ground crossings. It says you may choose to designate ground crossings. And it also encourages neighboring countries to cooperate by entering bilateral and multilateral arrangements concerning prevention or control of international transmission of disease, including joint designations of your ground points of entry. Ground crossings are special. They have characteristics that seaports and airports don't have. They have a surrounding land that usually may have border communities that straddle both sides of countries' borders, which are also integrated, the same people most of the time. They speak the same language. They have strong family and commercial tribes. The ties, the travelers may pass this ground crossing many times a day and not use a formal ground crossing, but several informal ground crossings which may not be manned. So a saying we have in Africa is that you may have your parlor or living room in one country side of the ground crossing, and you may have your bedroom in the other side. So there is a large amount of traffic that does cross, formally and informally. It can be trains, trucks or lorries, buses. People may be crossing on donkeys or just bicycles or on foot several times. And this poses special problems, as we will get to. And I thank Lionel for his question earlier. We will get to this in the Q&A. So also, countries may have a very large number of points of entry that are ground crossings. Apart from that, as I mentioned earlier, for every one formal point of entry that is a ground crossing, you may have anywhere between 10 to 100 informal unmanned crossings that also will require some attention. Many countries have very large land borders and thus poses a significant challenge manning. Now, ground crossings being contiguous and adjacent, that means the communities and thus the two countries or multiple countries are at risk of hazards from both internal and from the other side. Now, we did mention, as I was starting, about strategic risk assessment. That is the STAR risk profile of a country. There are several types of risk profiles: vulnerability, risk assessment and mapping, TIRA. But most countries don't share their strategic risk assessment results with their neighbors. It is done at a national level, and that risk profile is for the country. It doesn't get published on any big website. So neighbors may not know some of the hazards that there are in their neighboring countries, and which is why we strongly encourage information sharing. Strategic risk assessment also can be done at national and subnational level, but the most likely thing for most countries we have seen in Afro is that they have done it at the national level. They have not done it in provinces, counties, districts. And the risk profile for risks that are important, for hazards that are important at national level, may not be the same as at subnational level, meaning that some subnational units may have other risks that are very important and priority there that are not given priority at national level for planning. This can cause then a problem that if these are border provinces, the risk profile at national level that comes from the STAR may not reflect priority granular level risks that could be of concern to communities on the other side of the border to start preparing to respond. Ground crossing risk assessment thus needs to look at risks from experts on both sides of a ground crossing. Another point that you may not see on this slide is that for air transport and for sea transport, there is usually active radio communication with a control tower or a port. For an airport, a pilot can call in on the emergency frequency 1 to 1.5 megahertz that ICAO specifies and call in a mayday or 6 passenger on board or PAM medical that the airline has somebody in distress, and preparations can start on the ground before the airline comes into the port. Similar for the seaports, that will be the sea ships and liners and cruise passenger ships that will have some communication with the ports they are passing or with the operators. Ground transport may not have the luxury of these kind of communications continuously. So next slide, please. So as my colleagues mentioned earlier, thus, because of how many ground crossings you have to have many rationale or criteria that you're going to use to choose to designate a ground crossing. I will not go into detail of this. It's going to be in the slides shared with you of some of the factors you consider to designate some of your ground crossings. But as we say, when you are designating, you're going to need, next slide, please, to the pyramid. You're going to need to consider that every designated POE will require resources. So we don't want you to designate too many and you can't really provide the resources for their capacities to be built to standard that we expect globally. Next slide, please. So I just want to touch on the basis of the formula for the risk profiling assessments. That includes the STAR and the VRAM. Just a reminder that when you did or you are planning to do your risk profile, you are thinking of the risk of the hazard being a function of the likelihood of that hazard occurring times the impact on your society, on your population, on your economy, and so on, of that hazard onto your population. So in the context of the outbreaks we're having in Afro, what is your risk that filoviruses being imported or originating in your country will have on your society, population impact? And the lower formula you see there is that impact will be a function also of what capacities, gaps you have, which is your vulnerabilities, or the denominator, what capacities you do have, that is your strengths, and you're trying to build that denominator so that you reduce the size of the top part, which is the vulnerabilities. Now, the next slide shows you definitions of some of these terms, including what is a hazard, what is an event, what is an emergency, what is a disaster, what is resilience. This is taken from our rapid risk assessment guidance in WHO. Also note that exposures may be different. We're talking One Health these days. Exposures may be from biological, so your exposure will be a function of the number of people likely to be exposed. That is the next slide. And the number which is susceptible, which then ties into one of the expert groups that you will need to have when doing a ground crossing risk assessment, which is your immunization data and the officers that hold on to this, because they can tell you how many are susceptible to measles, how many are susceptible to yellow fever based on vaccine coverage. Of course, other considerations are, is it respiratory? Is it animal to human direct or human to human direct contact? And some things have dose response relationships. Now, it could also be physical. There may be a toxin or industrial risk from transportation of chemicals across borders. So you would want to know, is there a large industrial plant on the other side of the border, a chemical or refinery for petrochemical movement? These also you will assess using this risk assessment tool. Next slide, we're now on conducting the risk assessment. So to conduct this risk assessment, you need at first, as I said, to have some form of collaboration, ideally on the two sides of the border. Why? Because as you're getting the risk profile from your country, you also want to be seeing risk profile on the other side of the border. This will help you build a bigger picture. So you need to assemble a good risk assessment team. This should be multi-sectoral in the spirit of One Health, including public health experts from that area, as well as, if possible, the regional or national counterparts. Other departments, including agriculture, the security agencies, including customs, immigration, transportation, representatives of the ground crossing facilities, very important, leaders from the local community, religious and social groups. Now, we'll touch on this later again. You would also need to have special groups like transport unions and special professional groups, maybe traders or market women, youth, and other groups that can also provide some context on what they have in the community. To perform the assessment, the strategic risk assessment team, and the tool will be shared with you after the webinar. The team compiles a specific risk for that region, both sides of the border. That might be through discussions with experts in your area or through desk reviews. The next step would be then the risk categorization, which will determine the level and ranking of the risk using the Excel tool that will be shared with you. And each hazard will be assessed and given a risk level separately. As I said, this is based on the likelihood of the hazard occurring and the impact to the particular area of that POE qualitatively. The next slide, you will see an excerpt of how it will appear on the Excel matrix. We can't go into detail on this because it's a full topic for a webinar or a training on its own. However, I'll just talk about some of the parameters. You list the hazards in your area. It could be up to 10. It could be more, but we prefer that it is less. You would list your vulnerabilities. There are 5 questions there. The answers are binary, so the total score can be between 1 and 5. Then the next 2 would be looking at what the impact is going to be. So the severity assessment, there are 3 sets of questions. Question 1 is binary, question 2 and question 3 is rated from 0 to 3. And the total score will then take you to also up to 5, or lowest will be 0. The capacity assessment is very key. It asks very specific questions on what is expected to be in an ideal ground crossing that has all capacities. So there are 78 questions, yes or no questions. The total maximum score will be 156. The minimum score will be 0. Then the likelihood is almost Likert scale. It's 5 questions around very likely or very unlikely, and the scores go from 1 to 5. So as you plug each of these in, the top part that you see that is red, yellow, and green will give you where it falls for every hazard in the area. There's then a last sheet for mitigation measures, and all you have done previously is to come to this towards planning for mitigation in that ground crossing. As we said, you may not be able to have all capacities in all ground crossings, but having this kind of risk assessment will help you know which risks are the most likely from your side and the opposite side of the border, and what particular for that risk capacities need to be put in place. So does it have to have some VHF kits, or does it have to have PPEs for Ebola or Marburg, or does it need cholera kits? These are the things that when you see some of the risks in the red and yellow sections, you need to prepare at least for that if you can't prepare for everything that is on your long hazard list. So after the risk assessment, next slide. As I mentioned earlier, once this matrix is produced, the strategic risk team and decision makers use it to prioritize what capacities need to be there. The process will take into account what are the control measures that you have and what you don't have, and put in place. It's not a static document, this risk assessment tool. It works well when you also can be doing what Sarah mentioned around population, mobility, mapping, and PopCap. You need to think around also seasonality of risks. So this can change based on information that you have around what season, what outbreaks occur. And as we always say, this needs to be collaborative. You need to get free flow of information from your counterparts on the other side of the border, so you can identify what jointly capacities you both have, make joint plans, and very importantly, know what joint responses you will be able to mount. Is it joint vaccination campaigns? Is it joint wash interventions? The next slide is just basically on type of preparedness actions that will come out, and this is on another sheet for mitigation measures. So you can have your basic minimum preparedness actions for each of these risks. Some examples are just access to medical services, diagnostic services, equipment that has been described by my colleague Ningland. Do you have risk communications to make the border communities more engaged and trust the system more to report? Do you have environmental health control? You can also have then additional preparedness actions. Now, these, I'm hoping you're looking at the slide that has traffic light, green, yellow, and red. So what are the additional things that you will need? Contingency plan specific to those hazards that were identified as very high and high risk in the area. Funds that can be mobilized to upscale the capacities at those POEs when the risk is heightened. Collaboration cross-border, increasing communication and coordination during an event or an outbreak or something from a chemical aspect happening. Also thinking around, of course, One Health, animal sector improvements in capacity to isolate. What are your also emergency waste management structures? The next slide just shows you your objectives for surveillance at ground crossings. I will not go into details on this. These you can read on your own time when we share the slides. Just a last slide that is showing several of our guidance documents that many people do not know that WHO has published online and is free to download on contingency planning at POE, vector control at POEs, air transport management of emergencies, cross-border handbook, and public health emergency management for ships. I will stop here, and I'm hoping that we will discuss more during the Q&A. Back to you, moderator Lionel.
Merci beaucoup, Dr. Ibrahim. Je pense que maintenant la séance est ouverte pour les questions-réponses. On a déjà une question assez intéressante de notre collègue Dr. Kabamba Ngo-Yvon de la RDC qui demande ce qu'il faudrait faire en cas de conflit entre deux pays. J'imagine que ces deux pays font partie tous de l'OMS et ces deux pays qui se trouvent avec des relations bilatérales un peu difficiles. Comment faudrait-il se comporter ou bien quelle méthodologie apporter pour réussir à cette mission? Est-ce que vous avez une réponse au niveau des panélistes?
Happy to start. Well, if other panelists can follow, or if any panelists would like to jump in, perhaps I can start with some general comments. I think first of all, I would like to address the neutrality, health neutrality under the international health regulations. Of course, that we do understand that from theory, is a little bit different from what's going on the ground, but still it's worthwhile addressing. Under the international health regulations, and countries have the obligations and to report the surveillance information and to notify the other countries where there are disease outbreaks occurring. So you can find all the provisions related to surveillance report for outbreak response. Now, the understanding the complexity of the on the ground, in particular for this type of situation, when the countries have diplomatic frictions and so on and so forth. I think there are a few thoughts perhaps we could share. Of course, that really depends on the context, and I think that there won't be any one-size-fits-all solution. One thing is really to engage the impartial entities, organizations, and to engage the two parties, and as a technical committees, because again, health is transcend the frontiers, the borders. So if one is to engage the impartial partners, for instance, WHO, and to engage to facilitate the cross-sector, cross-border dialogues, and by, for instance, creating joint technical committees, this type of mechanism on specific health risks, so that will facilitate really the local level technical staffs sharing information and to jointly brainstorming on the potential health interventions that can be implemented. The other is engaging the local communities. I think in this type of context, the local communities is the key. The community leaders and the NGOs, health volunteers, and to really tap into their local language, local knowledge, and their local, let's say, the networks, and to facilitate this type of, to navigate, what can be done in practice. And then the other, perhaps the humanitarian or the healthcare corridors, I think are similar to the first point I addressed, and really to engage again the impartial partners, and to create this type of humanitarian corridors, and to facilitate really health specific matters, and so the borders and two borders can really engage in the dialogue to facilitate the process. This definitely is a very, very difficult areas to explore, but I think these are some thoughts that we can put on the table and for discussion. Also, I think that the colleague who raised the question, he's from DRC. I think DRC is definitely presents our country context where this type of a situation might happen. We would actually like to have all the participants who contribute to your ideas, because in many of the countries, you might come across similar questions, so that we, brainstorming and to get your experiences of tackling these type of questions will be useful to inspire each other. Really, if there are any colleagues who would like to share experiences, please feel free also to use this platform. Thank you.
Merci beaucoup, Dr. Wang. Je pense pas que ce soit une question, mais c'est juste un commentaire qui dit que, par exemple, nos portes d'entrée sont toujours en train de mettre l'accent plus dans la riposte et non dans la préparation. J'imagine que la question est peut-être de savoir comment maintenir un niveau pas d'alerte, mais un niveau de préoccupation tout au long pour éviter de faire de répondre seulement quand il y a une menace déjà dans nos murs. Je ne sais pas si j'ai été fidèle à votre commentaire, Monsieur Kainak Kama. Ibrahim Mamadou. Amadou, over to you.
Yes, I'd like to thank colleagues on the comments they raised. And indeed, when we are trying to preach this message of increasing your capacities during preparedness, that is like during the time when you don't have an outbreak, it's key that you understand that there's quite a few of guidance documents that you can use, including the ones that we showed during the slides. It ties into also a question earlier that somebody asked about integration of the African region. How does that tie into screening at the borders? Now, you need to understand that while you're trying to encourage, as IHR says, travel and trade, you also want to protect your countries. So there's guidance documents. Ninglan mentioned earlier that Africa CDC, WHO, and other partners worked on a cross-border information sharing framework. We in WHO Afro are also working on a border health POE guidance document in tandem with the IHR for the Afro region, which will bring in many of the elements of what you member states need to do to strengthen yourselves. But a very important aspect around being ready during time of preparedness is building your trust of border communities. These communities are very integrated. These communities may be the barrier between one country's border and the other because of informal borders. So they have to trust your event-based and your formal-based surveillance systems. They have to trust the health systems so that when people come into another side of a country, they know where to report. They have the right information from your risk communications and community engagement. They know what is an unusual illness, even if they need to be reporting people that are their relatives, their tribesmen. They need to know that there is a government system that will help these persons, and it's in solidarity. We, in the African context, we may not have so many of travel clinics, but we also want to leverage the advantage of having things like mining unions, market women, traders unions, bus and truck unions, to also build trust with them so that these information flow in from event-based surveillance into formal systems, and we are able to respond. In Mpox, several of the transmissions happened cross-border among these types of groups, and it wasn't at the screening point at the border that it was picked. It could have been further inside in a travel corridor or at a convergence point. So we need to build those networks of trust strongly in Africa to ensure that even if the screening at the formal POEs does not pick, they are still able to report into IDSR or other surveillance systems. I will stop here and hand back to my colleagues.
Merci, Dr. Ibrahim. J'aimerais inviter les participants à poser leurs questions directement. Vous n'avez qu'à activer votre micro. Mais aussi, c'est pas seulement que les questions. Si vous avez une expérience que vous aimeriez partager de votre pays en rapport avec le sujet d'aujourd'hui, vous avez la parole. Je vois notre collègue du Togo, Dr. Dovi, à vous la parole, suivi de Dr. Maouli Gaga. Dr. Dovi.
Ok, merci beaucoup. Je voulais revenir sur l'autorisation des ports, des points d'entrée maritimes pour la certification des navires. Bon, je voulais qu'on revienne un peu sur les conditions, puisque j'avais compris que les pays membres sont exhortés à envoyer le nom des ports qu'ils voulaient autoriser pour la certification à l'OMS. Je voulais qu'on revienne un peu sur ça. Merci beaucoup.
Alors, je ne sais pas si on peut prendre l'autre question aussi, comme ça, on répond aux questions ensemble. Oui, monsieur, madame Maouli, à vous la parole.
Ok, bonjour à tous. Pour moi, je pense que ce n'est pas une question, mais c'est un commentaire. Je voudrais revenir sur l'évaluation des risques dans les cas de conflit. Comme ça a été soulevé par un collègue de la RDC, les réponses nous ont proposé que si on doit travailler avec les ONG, même avec la communauté, il faut qu'on ait l'adhésion des politiques des pays frontaliers. Parce que lorsque nous allons finir l'évaluation, il va falloir qu'il y ait une prise de décision après par rapport au renforcement de capacité au niveau des points d'entrée. Et là, si nous n'avons pas leur adhésion, vous pensez que ça va être compliqué pour qu'un renforcement de capacité va être fait après l'évaluation. Donc, je pense que ce point-là, l'OMS peut nous aider à pouvoir vraiment toucher les politiques par rapport à l'importance de ce que nous voulons faire au niveau des points d'entrée. Merci.
Très bien, merci beaucoup. Je passe la parole aux panélistes. Ensuite, on va passer la parole à monsieur Florimond et monsieur Kainak. Chers panélistes, à vous la parole.
Yeah, thank you, Lionel. Perhaps I can take the question on the port authorization, just to have a few words on that. So the authorized ports is, as we highlighted in the slides, this is a mandatory requirement for WHO, for countries and to submit that list of authorized ports. So we can share that link of the current list of authorized ports, which are submitted by the countries. Now, for countries who haven't done this, I think the priorities is really to identify the ports where you have international maritime traffic. You have mentioned international maritime, the ships, the cargoes come to your countries, and to see whether you have qualified, competent ship inspectors. And with that, you can submit with it's your country's discretion and our decision, and to identify the ports and share with WHO and make very specifically clear, like for that port, do you authorize them to issue ship sanitation control certificate or exemption control certificate? Or just to give the extension of the certificate. All the ports can give an extension of the shipping inspection, ship sanitation certificate for 1 month. So this is totally at the hand of the country. I don't know if I have addressed your question. And then, of course, WHO has our training program for ship inspectors. So that includes online module and the face-to-face module. We can also share the link for this online training, so that the countries, you can access that training materials to train your ship inspectors. Thank you. Back to you.
Merci beaucoup, Dr. Wang. Nous avons encore 5 minutes. Je voudrais demander à M. Fleurimont et Kaina Kaba de vraiment utiliser 1 minute pour poser leurs questions de façon très concise afin de permettre à nos panélistes de pouvoir y répondre. À vous, M. Fleurimont. 1 minute.
Oui, allô, bonjour.
Oui, bonjour, on vous reçoit très
Merci.
bien.
Moi, c'est Dr. Choko, je suis un ancien de l'OMS. Je voudrais d'abord féliciter rapidement les organisateurs. Je vois Dr. Nigland et tout le monde. Et ce n'est pas une question comme terme. Hein. Nous sommes très heureux de participer à cette mise à jour des connaissances et des formations sur les règlements sanitaires, et surtout particulièrement pour le point d'entrée. Ma question, c'est de savoir, aujourd'hui nous sommes ensemble, nous sommes une centaine. Comment toutes ces nouvelles mises à jour parviennent au pays? Et est-ce qu'elles sont mises en œuvre? Parce que nous voyons dans des pays vastes comme la RDC, lorsqu'il y a une épidémie qui touche 2 ou 3 provinces, la notion de point d'entrée et de frontière n'est pas très bien comprise. Parce que vous allez voir sur les routes, des gens érigent des barrières et commencent à faire les contrôles. Alors, en ce moment-là, il y a la confusion avec le point d'entrée et les postes frontières. Je pense que c'est extrêmement important pour l'OMS, toutes ces notions de nouvelles notions que nous apprenons aujourd'hui parviennent au pays à temps et que le séminaire soit organisé avec les États membres et les personnels qui sont au fond sur ces nouvelles questions. Merci beaucoup.
Merci beaucoup, Dr. Chioko. Monsieur Kainak.
Oui, bonjour tout le monde. C'est pas quand même une question, mais juste une contribution. Mais d'abord, je voudrais vraiment magnifier cette rencontre pour moi qui est une première. Et vous remercier aussi pour le commentaire que vous avez bien relaté et merci beaucoup. J'interviens en tant qu'acteur qui a travaillé sur les points d'entrée pendant au moins 10 ans. En tout cas, c'est l'expérience du terrain. Je suis au niveau du Sénégal. Et ma contribution, c'est quoi? Je voudrais que les gens puissent mettre l'accent plus ou bien tester ce qu'on appelle les corridors de santé publique. Le corridor de santé publique, je pense que c'est quelque chose qui pourrait bien nous aider en tant qu'acteurs, mais qui contribuerait vraiment à aider, en tout cas à faire face aux urgences de santé publique au niveau des points d'entrée. Le deuxième commentaire, ou bien la deuxième contribution, c'est insister sur la formation de tous les acteurs au niveau des points d'entrée, c'est-à-dire les personnes qui interviennent sur comment détecter, comment séparer, comment notifier tout cas de santé, tout cas de cas suspect de maladie à potentiel épidémique. Je pense que si les acteurs qui interviennent au niveau des points d'entrée puissent détecter, notifier, là on gagnerait. Et que vraiment, j'insiste sur mon commentaire pour dire que les gens insistent beaucoup quand il y a uniquement un événement. Mais quand il y a un temps de paix, vraiment, on ne sent rien au niveau des points d'entrée. Et c'est ça là qu'on devait mettre plus l'accent. Je vous remercie.
Merci beaucoup, Monsieur Kainak. Commentaire bien noté. Je passe la parole aux panélistes s'ils ont quelque chose à ajouter ou un éclaircissement à donner à nos deux participants qui viennent de poser des questions ou des commentaires. De façon très brève.
Perhaps just a suggestion, Lionel, and yeah, I just perhaps speak, from WHO side. I think Dr. Shoko has made a really nice nice seeing you again, Dr. Shoko. So I think that he made a good point that how we always make this type of information available. Indeed, the refreshing training and the sensitization is very important because we have a very high turnover of staff across, almost all the work areas. So I think this type of refreshing training and to understand, to articulate what's the difference of the points of entry and the border house. Because again, as he also mentioned, that at the points of entry, people do not really understand the points of entry is about what. We're talking about the traveler, everything working across points of entry prior to points of entry, post, after the travel, during the points of entry. I think Dr. Kanak also mentioned somehow the travel corridors. So we're really looking at the travel continuum. I think that presents a good scope of the border house and the points of entry in general. I hope that we will have in the future chance like that, and we can go in depth to each area, air, maritime, ground, land borders. Of course, we will work with our Afro colleagues together to have, to explore more opportunities. Thank you. Back to you, Lionel.
Merci beaucoup, Dr. Wang. Je pense que nous avons déjà dépassé plus de 10 minutes. Je tiens à remercier la centaine de participants qui s'étaient connectés pour ce webinaire important. Le nombre de participants montre exactement comment ce sujet est assez important. Nous avons vu durant ce webinaire que nous avons parlé de la santé au niveau de la frontière. On a défini ce qu'on entendait par santé au niveau des postes d'entrée. On a vu les dispositions clés du règlement sanitaire international concernant les points d'entrée, ainsi que les capacités requises en vertu du RSI même. Ensuite, on a vu aussi les aspects pratiques concernant la santé aux frontières et on a parlé aussi de comment procéder à l'évaluation des risques à nos portes d'entrée. Je vois la main du docteur Ibrahim. Je ne sais pas s'il veut dire quelque chose, bien si c'est une main ancienne. Docteur Ibrahim, avant de conclure.
Thank you very much, Lionel. Thank you, colleagues. I just wanted to make one or two announcements. In the Afro region, as Ninglan has just touched on, we are trying to plan a webinar series that is not just now around the context of filoviruses, but into much more details of each of the sea, the air, the ground crossing, so that as Mr. Kama and other colleagues have said around improving continuous learning of these topics. So we're going to announce that soon for Afro region. It's still being planned. Also in the Afro region, we're trying to finalize a framework for border health and POE's document for WHO Afro. that will be shared with all the countries in the region that will help you understand the broader background of all of the topics we're talking about. I also just want to quickly encourage our colleague Sarah mentioned around, and Ninglan also mentioned around the guidance for screening, that there needs to be more research put out there. And I do know in our Afro region, from COVID experience and Mpox experience, many of our countries are sitting on a lot of screening data that they could analyze and make into publications. That will help us increase the science in the world around what are the advantages of screening. So please, colleagues, go back. I'm sure you have, over the past few years, collected a lot of information that you have not converted into academic research. Please go back and publish for Afro to also be visible, Africa to be visible on what we're doing to the world. I thank you, and I hand back to you, Lionel.
Merci beaucoup, Dr. Ibrahim. Donc, c'est sur ces commentaires, ces encouragements de Dr. Ibrahim que nous allons clôturer notre séance. Comme cela a été dit au départ, nous allons partager les documents utilisés durant cette séance avec vous après ce webinaire. Et sur ce, je vous souhaite un bon après-midi et merci encore d'avoir participé à cette session. À très bientôt.
Merci. Au revoir.
Merci à tous.